working? Perfect, thank you. Great conference. And I actually wish, as listening to these talks, Jeremy said, so there's going to be a slant this year. We're going to talk about finances. And I said, that's fantastic. I did come out here and I got my MBA when I started, so I'm clearly a finance guru. I don't know if any others got their MBA, but it's like when you become a doctor, the first year you're out, you're really not prepared to take care of people for probably about 5 years. And the same thing goes with your MBA. I'm still just trying to figure out the language. But I have a great talk, and I'd rather give that one than this one, but especially because Alex spoke, and I hate talking anywhere near Alex when we talk about business. But anyway, I'm going to talk a little bit about MIS and whether MIS has delivered on its promises. So I'm going to try and do it in a little bit of a unique way. These are my disclosures, and they're relevant because we have our industry friends back there. I have twin daughters. They're kids number 4 and 5, and they're about to start USC this fall, so I'm looking for work. I wash cars, landscaping. If anybody's interested in adding to my disclosures here, give me a call. Okay, so MIS. Everybody's seen the marketing out there. We've seen the pictures. We've seen the Laser Spine Institute. This lady clearly had surgery yesterday on her back. You can see the large or the small Band-Aid on her back. And this is what's marketed. This is what MIS is to the general public. But we really don't talk a whole lot about the durability of these MIS procedures, fusions in particular, the cost savings, the scalability. So I'm going to try and kind of impose some of that here. We know the advantages. Oops, I think I got to click through here. We want to get patients back to being themselves, and we want to do it with fewest complications. We want to do it with the smallest footprint. Get folks back to being who it is they are. And that's what MIS is supposed to catalyze, right? But it's also, along with that, it's catalyzed an arms race in technologies, because in order to employ a lot of these less invasive techniques, you have to bring the technologies to do so. It's catalyzed the adoption of robotics. Marketing, it's a marketing differentiator. To be the MIS guru in certain facilities, it's marketing for you, it's marketing for your fellowship. And it also, of course, marketing or for the hospitals to be able to take those cases and move them out to the ASCs. But what we don't, again, talk about is some of the other things, such as smaller incisions does not always equal smaller operations. In fact, sometimes these operations take longer, especially when you're in that learning curve. And the learning curve, depending on what you're doing, especially endoscopy, can be very, very long. Even though steep, it can be very, very long. These can cost more money because now you're reliant on more expensive machinery. You can have increased complications, especially if they're poorly performed or early on in the learning curve. It also shifts a lot of the complexity of the procedure to the surgeon. So it's a heavier cognitive load, leads to greater exhaustion at the end of our days. You're less likely, if you work in an academic facility, to be able to have the residents doing portions of these operations. You have to be there for more of it. I think it also has enabled some surgeons that have adopted the MIS techniques to skip those early mastery, that phase of time where you have to become an expert or a master in the fundamentals of specific operations. I know folks that came out, we had some of the fellows when I was at Pitt, they knew how to, they were informed of how to do MIS TLIS, but they had no idea how to do them open because they hadn't had that exposure, which was a unique finding and something that's a little concerning. So Rick Fessler is one of kind of the godfathers of modern day minimally invasive surgery. And he put this out about a year ago and he started asking questions. Is MIS, is this really meaningful innovation at this point? And are others going to follow in these opportunities to demonstrate? Because MIS has been around for a long time and it's being employed more and more, but it's slowly iterative. There's still a lot of folks doing a lot of really open procedures, and we have to start asking ourselves, why is that? Is it something that's for all surgeons? Are the benefits powerful enough to change others' practices? And there's a whole slew of other questions that we can ask. Are we changing the complication rates? Are we changing the complication profiles? And at the end, when we get to all this, one thing that I think MIS was nice and that it was supposed to do for us, it creates a very clear and concise workflow. Is that to do an MIS operation, this is how you have to do it. But what it really did is expose the tremendous variability that exists out in our workforce. This is a summary of MIS techniques. Looked at endoscopic, lateral interbody fusion, robot-assisted perk screws, and if you look all the way right, you can see what was the real outcome here, what was everyone trying to achieve? Faster recoveries. That's what we were all trying to do, but if you really think about what MIS brings to the table, this was put out about 6 years ago by Roger Hartle. He did a comparison of invasiveness versus complexity, and if you look at the less complex, the simple cases, the microdisc, the mini lamies, there's really not a tremendous benefit to incorporating MIS techniques to the more traditional techniques. If you look at the really, really complex stuff, the high-level complex, severe deformities, again, that gap is quite small, but it's the stuff in the middle where MIS can potentially be helpful. It's the few-level interbody fusions. And so what I thought I would do is give kind of a pictorial evolution of how I incorporated some of these interbody fusions into my practice, starting back in 2007 or so, and into more modern world, and show how that MIS benefit zone adapted for me. So again, back in my fellowship at UCSF, in the room adjacent to Chris Ames, we started employing these interbody techniques, and then I went in 2008 to Pitt, and I joined forces with this guy. So I was doing a lot of MIS. This is David Okonkwo. He was my partner, and he was the deformity guy. We both trained under Chris Shaffrey, so we had a great working experience. We trained at UVA together. He went to Pitt and then said, "You got to come to Pitt. Let's combine. Let's figure out how to do some of these cases together." I wasn't a huge deformity fan, but I loved working with him, and it started giving me a greater understanding and appreciation for how it is that we can work together, because there's nothing better going to work than working with your best friend and being able to do that in the operating room. And it was very clear that interbody fusions, these were very powerful procedures. We can get a lot of tremendous alignment with these large grafts and significant indirect decompression. So do very, very small incisions. And we're better to employ new technologies and techniques than in deformity. I wasn't quite sure how this was going to play out in the long term, if this was going to be a workhorse that I could rely on in these lateral interbody fusions. But in deformity, we know we want these levels to fuse. So it seems like a reasonable place to start. Why else? Well, when the ISSG looked at almost 1,000 cases in succession, what they found is that if they looked at the patients that had complications versus the one that didn't, and they grouped those together, the majority of the major complications appear to be more related to the procedural variables than to the patient variables. So the number of stages and the surgical approach that was taken. So we began incorporating and doing these high-bid operations where we were including MIS in all our deformity cases, and we were publishing. But everyone knows spectacular achievement is always preceded by unspectacular preparation and failures, iterative failures. Here's actually a neuroradiologist at Pitt was Big Agrawal, and we got together and collected. We did 1,262 deformities that incorporated lateral access in interbody fusions into those cases. Some were circumferential IMS, some were hybrids, some incorporated a little bit of both, but at the end of the day, we had a large volume, and we had, of course, our share of issues. And these aren't just ours. I mean, this is some of the other groups as well at Pitt, but we had somas hematomas, we had a bowel injury, we had incisional hernias, we had subsidence, we had coronal split fractures, we had migrated cages. When you do thousands of cases, this is what you're gonna see. You have to be prepared for that. It's still around, right? Lateral is still around, so clearly there's been benefit to it. But this was my very first patient, January 4th, 2008, that I incorporated lateral. This was a 70-year-old woman that no one was going to touch. Sickly lady. She had antrolisthesis at 4 or 5. This was before we were really getting our long-standing cassettes on everyone. She had a posterior listhesis or retrolisthesis at 2-3. Her deformity was significant. Again, I can't show you her SVA here, but it was dramatic because she walked like this. At least her functional SVA was dramatic. And this was my first case. And these are 18-millimeter smooth peak cages. Did them at every level. The spondies were doing. I'm like, wow, is this the golden boy? What have we got here? This is fantastic. So here we are 6 weeks later. Right, subsidence at every level. Her symptoms are not that all her symptoms were gone, but she was pretty darn good the first couple of weeks. And at 6 weeks, she's saying, you know what, I'm starting to have my pains back, and in fact, it's getting worse on the left leg. And here we are a year later, and you can see the benefits of the surgery gone. I mean, everything was right back to where we started, except now she has these grafts, and we ended up doing a pretty extensive operation. It took a while to get her to be optimized, but ultimately we were able to get her back in the operating room. But the point is, this is the beginning of our of the evolution. At least it was for us in Pittsburgh and for myself. There's another patient that had a relatively substantial curve, but we thought, what if we turn these rigid curves into flexible curves? I'm getting the 5-minute mark here, so that's unfortunate because I got about 45 to go. Let me move. So we wanted to create flexible curves. Started coming from the back, doing our osteotomies, and then putting these in from the side. And again, it was super easy now that we have a flexible spine because we started with the osteotomies, and we didn't have to do much leveraging to actually correct the deformity. And these are durable results. This is a year out. Again, we published. We incorporated the laterals in with PSOs. You can see on the right, and here we started incorporating with ACR, anterior column reconstructions as well. Significant deformities. Here's a case where we would do above and below. We'd put laterals, do an ACR in the middle, and then in the same position, single position surgery, we'd come from the front, do a single A-lift down at the bottom through that MIS portal. And here's the post-op before we actually put the screws in. So you can see, if you look at pre-op before the ACR and the A-lift, both of which were MIS, and post, in both the coronal and sagittal plane, including the SVA correction, it can be pretty dramatic without having put in a single posterior screw. And then we go ahead and we have our rod shaped and we put it in. This isn't perfect, but this is, 2009 or so when we're starting to incorporate some of these. But the point is that the posterior operation is super fast and simple when you've already done a pretty tremendous correction. Here's where we start adding them above previous constructs, so we would have to do less work in previous levels. Here again, MIS A-lift, and you can see after stage 1, we've got pretty significant correction in both the SVA as well as the PIL mismatch. So we were pretty happy with how this was going. Single position surgery. We started doing surgery from the back. And let me move through. This is the two of us working together, me performing lateral at the time that the Okonkwo was doing decompression from the back. And then we went into the whole prone single position. And that was a different experience for a different talk. But you can kind of see a little bit of discomfort there as I'm sitting trying to perform these operations. But there is an evolution in the data, and I will zip through this. We initially began looking at our films, and what you'll notice is the top is pre-op lumbar lordosis and pelvic incidence. Lumbar lordosis is in blue. We know that we can affect lumbar lordosis, and you can see in post-op, that's our first 25 patients, we were getting those to line up. We were getting them within 10 degrees, which was a significant contributor to improvement in our patients. If we look at how patients were doing, the more open the procedures were, the more we were able to find that we could correct our spinal pelvic parameters. So we weren't doing as good of a job actually getting SVA correction, PL mismatch, our pelvic tilt. But interestingly, if you look to the right, you'll see our patients were still doing really well. In fact, they were doing that with a quarter of the blood loss and a third of the complications. But there was a ceiling effect. We were able to only get about 23 degrees of correction if we did entirely standalone interbodies. If we did circumferential IMS with it, put in purse screws, we can get about 34 degrees. But the minute we opened them up from the back and began employing some of the compressive techniques, we'd get up to 55 degrees, which is pretty dramatic difference, right? So there was definitely a ceiling in our ability. Complications, a lot of the big difference between MIS and open was in our intraoperative complications, far fewer. Created an algorithm that helped us to kind of determine which patients would be appropriate for MIS versus hybrid versus open. And if we looked at our best and worst outcomes, though, it turns out it is really important to correct those parameters. At least that durability is important in long term in our young patients. But if we look at the elderly, we found that MCID was a lot less reliant upon correction of those parameters. So let me get to our reoperation rates, again, significantly lower. Actually, the reoperation rates MIS open weren't different. The complication rate was significantly lower. In fact, it was half that, but it wasn't altering the reoperation rate. So that's different. I'm going to move through this so I can get to kind of the part where I think you'd be most interested. This is where we attached ACRs to Schwab modifiers. Came up with MIS DEF2 to, again, help guide where those patients should land. At the end of a learning curve, we looked at 8 years of experience. We found that, when I say we, I mean the minimally invasive team of the ISSG. So this is a large number of centers where we're pooling our data, and we were improving correction. We were paying more attention to our alignment. We were operating on fatter and older people. We were having meaningful improvements, fewer complications. Our operative time decreased by 47%. but we didn't tell you that our operative time increased by 100% for the first 50 cases or so. So we actually just got our numbers back to where they should have been as far as the time goes. But the promises, and I'll be quick here, who are we making those promises to? Certainly we're making them to our patients, that we're going to get them back to their life, but it's not the marketing, the big picture with the Band-Aid on the back that patients are so concerned about. Right? It's very rare. Anyone ever come back to you after you do an MIS operation and go, you know what, my incision's an inch larger than I thought it was going to be. That's not common. They're not necessarily looking for their smaller scars. They're looking to return to the life that they lived before they started having the symptoms. And there's lots of data now. We've got distinct recovery patterns after TLIF for open versus MIS, looking at the narcotic usage after these long-term clinical outcomes, complications over a 10-year period. It turns out that 4 out of 5 patients that have MIS fusions are highly satisfied. These are durable results after having had their operation. ODI scores show about 4-week improvement, earlier recoveries. Opioids decrease dramatically, and length of stay, of course, is significantly shortened. It's delivering. MIS is delivering on this to our patients, but consistency does vary depending on the surgeon's experience and the technique. What about the promise to the surgeons? Empowering the surgeon with technology. That's an extension of us, right? These are assistive tools for the most part at this point in the game, but the tools are making us more precise. It's extending our careers in theory. That's what it's supposed to be doing. We're supposed to have less radiation. Sorry that this is kind of working so slow here, but we're also supposed to have improved access to these educational opportunities so that when we're performing these, when we're learning these things, we can shorten that learning curve. Again, lots of data now showing current trends and emerging enabling technologies, advanced challenges, navigated screws. We can look at the data all day because it does exist. Robots, these are new techniques, technologies, and training that is going to increase our MIS benefit zone. Turns out that when you add robots, 94% accuracy, some folks are going to say, you know what, I can get 94% accuracy without the robot. That's true. Every time we employ, and Chris, you might talk about this in your talk, we talked a little bit about this last night. Every time we incorporate smart tools into the operating room, we get better. And when I say we, the patients are having better outcomes. The patients are having better play screws. They are. And it's interesting that when we bring the humans into it, we actually lower some of that accuracy. So I think it's something we need to be wary of. Our reduction in radiation has been real, and our industry partners are working very hard to create these ergonomic tools so that we can do this. The MIS promise to our hospitals, we tell them we're going to move them all out into the ASCs. It's going to be efficient and it's going to be more profitable. Is that true? Have the hospitals felt that MIS has been a positive initiative? There's lots of data. Acute hospital costs, budget impact, in our hospitals comparing MIS to open, looking at as we shift these patients out into the ASCs, how we're doing. Well, studies are showing about $2,800 per case in savings. You compare MIS procedures to their open counterparts. We're eliminating ICU stays, and of course, the patients are being moved out into the ASCs. But this does require significant upfront investments from our hospitals in the tools that we need to perform these. And lastly, MIS, the promise to the payers. We're going to shift value economics to our payers, right? Remember what the payers really care about? They're not necessarily looking about that single hospitalization. They are looking at the total cost, the total episode cost over months and over years, how much they're going to have to pay for that individual over that period of time. We have data, cost utility of lateral, systematic views, predictors of return to work, looking at endoscopy. Well, approximately $15,000 to $32,000 is now the cost for an MIS TLIF. In the quality adjusted life years. So if you look, someone that's living perfect health is a 1, someone that's dead is a 0. So you figure out where they land from 0 to 1, and then you multiply it by the number of years. That kind of gives you your quality. So the point is that quality. This was determined to be about $44,000 for open, and down to as low as $15,000. So it's pretty dramatic savings to increase quality adjusted life years for patients with these MIS procedures. Patients are getting back to work on average about a month or so faster than if they had an open procedure, and the post-acute costs are lower. So in summary, for the patient experience, we're delivering. I do think we are. I think we are doing right by our patients. As long as we're picking them properly or performing appropriately indicated patients on the right individuals, we're getting them back. We're accomplishing that goal. As far as surgical precision and system value, that's emerging. That's coming along. Democratization, this is really where we're suffering, and it's very limited. Getting these technologies into our ASCs, into our community hospitals area. Hoag is, of course, unique in that we've got such strong foundations and such wonderful support from our community, but that's not true of most places. But the potential is very strong, and that as we shorten that learning curve and get our folks out there that are trained at a very high level, understanding the basic fundamentals of what we're trying to achieve, and then teaching them these MAS techniques, I think we have a strong future ahead of us. But the more we incorporate AI, I think one of the things we have to think about is the future minimally invasive, or is it maximally intelligent? And that's where we've got to combine the two. And appreciate your time. Thank you. Sorry for being over.